Good afternoon. My name is Fran Kritz, and I'm a contributing health and medicine reporter for the Washington Post. This is the concluding panel for today's program, and we have with us 4 world-class experts to discuss innovations in prevention, detection, and the treatment of cancer. Dr. Regina Barzilai is the Delta Electronics Professor at the Massachusetts Institute of Technology, Computer Science and Artificial Intelligence Lab. Dr. Barzilai's research focuses on natural language processing and machine learning. After a diagnosis of cancer 3 years ago, Dr. Barzilai added a new direction to her research, applying artificial intelligence and machine learning to improve cancer diagnoses and treatment methods in collaboration with researchers at the Massachusetts General Hospital in Boston. Dr. Otis Brawley is the Chief Medical Officer and Executive Vice President of the American Cancer Society, where he's responsible for promoting the goals of cancer prevention, early detection and treatment through research and education. Dr. Jill Hagencord, a molecular pathologist, is the Chief Medical Officer at Color Genomics, which offers consumers, as ordered by their doctors, genetic testing to help understand risks for common hereditary cancers. And last but not least, Dr. Douglas Lowy is the Acting Director at the National Cancer Institute. Dr. Lowy is a renowned expert in the areas of cancer biology, papillomaviruses, preventive vaccines, and tumor suppressor genes. And thank you all for joining the panel today. I'd like to remind everyone in the audience and those watching online that you can tweet your questions using the hashtag #PostLive or leave a comment on the Facebook live stream. Let's start with Dr. Barzilai. Dr. Barzilai, what are you and your colleagues doing that will help physicians use computers to refine cancer diagnoses and treatment?
Whatever I'm doing with computers and machine learning was impacted by my own experience as a breast cancer patient at MGH. I was treated very well. But one thing that really struck me is how much uncertainty patients have and how much all this data that is collected in the hospital is really not used. And as a patient, I saw that I was an exception. But once I was treated, I was actually looking at the website of American Society of Clinical Oncologists, and I found statistics that I found to be a travesty. That statistic says that today, all the clinical decisions are based mostly on 3% of the populations that participated in clinical trials, which means that tons of data that is collected about the patients, people like me who were not part of any clinical trial, is not utilized. And when the whole process of cancer treatment, and we've heard it from the previous speakers, has so much uncertainty, and it's really a non-deterministic process where big data can make a huge difference. So after I came back to MIT after the treatment, I decided I'm going to change it. And I was lucky enough to find doctors at MGH, Dr. Kevin Hughes and Dr. Constance Lehman, who also believe that the situation has to be changed. And together with my student, we started this journey. So the first things that we've done was actually to take this big data, and the previous speakers were talking about in the area of breast cancer pathologists, which currently is not utilized. And if you look even at the top journals in pathology, many studies are really, really tiny, because now it requires somebody to sit down and encode information by hand to do the study. So we decided to change it. We took all the pathologies available from breast cancer from partners, and we translated the free text into a database. So now you can automatically identify all the women who had this condition and maybe in 5 years recurred. You can easily identify the populations that you need, and there is no human in the loop. The database currently has 160,000 reports, which are coded in these 20 fields. So it's a very large database. It spans over 3 decades, and it's already used in many studies that look at cancer progression and the development of a TPS. Another direction that we are working on, and again, impacted by my experience as a cancer patient, is to better utilize imaging data that we have. So currently you do your mammogram, it's a pretty large image, it's 3,000 pixels. It's read by a human who can only notice limited amount of information that is in this mammogram. And then it's summarized into a short text. And a lot of information is really lost here. machines are really good in reading, millions of these mammograms and answering questions which humans cannot answer today. Like, for instance, to do personalized risk assessment of breast cancer given specific tissue of the woman. So you can train machine to take this image and say, what is the likelihood in 5 years that the patient may develop cancer? Or to see whether the patient, like myself, who is on medications, responds to medication or not. And variety of other questions. Is a woman heading towards recurrence? So all this data is available. There are a lot of progress. I'm sure you all learned about deep learning. So instead of using deep learning to recognize different types of cats, we are trying to use it to learn about development of cancer.
Thank you. Dr. Hagencourt, let's talk about your vantage point as the head of at the helm of color, and that is, what are some common misconceptions that people have about genetic testing, and what can we do to change that?
Common misperceptions about genetic testing. First, it's important to always be clear what we mean when we say genetic testing. A lot of times people think I'm talking about the DNA that's inside somebody's tumor, and we do testing on, color doesn't do it, but people do molecular testing and genetic testing to look at the DNA of tumors. And that can often tell you how the tumor is going to behave or what drugs it might respond to. The kind of genetic testing that color does is looking at all of the cells in your body for an inherited predisposition to develop cancer. And one of the common misperceptions about that kind of genetic testing is that it's deterministic. That if I look at your DNA, I can somehow tell you exactly what's going to happen, and you're definitely going to die of this kind of cancer at this decade of your life. And that's not really true. And that might seem like a bad thing, but I actually think of it as a good thing, that it's not deterministic. So if you've got a mutation in the BRCA1 gene, for example, and you're a woman, we know that you've got like a 70 or 80% lifetime risk of getting breast cancer. So we know that you're playing the game of life here, and you've got loaded dice, and they're loaded against you. But because we can actually look at your DNA and see that you've got a mutation in the BRCA1 gene, we can actually say, hey, psst, dice are loaded, and you can ask, for some different dice, right? You can do preventative things to reduce your chance of getting that breast cancer that you're at 80% lifetime risk for. So you can do things like just increase surveillance. Instead of waiting until you're 40 or 50 to start mammography, you can start at a younger age, and you can fold in MRI on top of it. Or you can take certain medications, or you can even have prophylactic surgeries. But all of these things are shown to reduce your risk of developing breast cancer and ovarian cancer. And kind of akin to that concept is that not all genes are created equal, and that we have some genes that when there's a mutation in those genes, they're really impactful. And that would be something like the BRCA1 and 2 genes, or the Lynch syndrome genes, where you know that if you've got a mutation in one of those genes, you have a serious risk of actually developing one of those syndromic cancers in your lifetime. Then there's moderate risk genes and low risk genes. And this is the part of the genome that we're still really trying to figure out how they work together with genes and environment. But definitely the more you get down on this end of the spectrum, where you're dealing with the moderate risk genes, something like a CHEK2 or an ATM in breast cancer, there are more opportunities to shape your destiny. That genes definitely aren't your destiny. It's neither necessary nor sufficient to get breast cancer, but it does put you at an increased risk, and it empowers you then with the ability to work with your healthcare provider. And even if, based on your personal and family history, maybe they don't decide to do any overt clinical action, there's a personal utility and a heightened awareness, and being kind of more conscientious about going to your regular population level screening programs. And then also in your family history, that kind of moderate risk gene could also drive you to some of those increased surveillance options that I mentioned earlier.
Thank you. Dr. Brawley, following up on what happens to people who may not even know that they have cancer, may not be being tested and know about going for testing. In 2012, you published a book titled How We Do Harm, A Doctor Breaks Ranks About Being Sick in America. And it talks about your frustration with the inconsistency of cancer detection and treatment in the United States. How do we begin to change that?
Well, number one, we need to realize that everybody deserves good health care. One of the problems that I have, let's just look at some very simple statistics. We have had a 35% decrease in the death rate from breast cancer in the United States since 1991. It's a wonderful thing. There are 12 states that have not had a 10% decrease. Why is it that people who live in Massachusetts have done very well from breast cancer, but people who live in Mississippi and Arkansas, no? It's because medicine is not practiced in a regulated way where everybody gets the care that every human being deserves. We need to talk about evidence-based medicine where we practice what the evidence actually says. This is the most expensive health economy in the world. We spend $10,000 per man, woman, and child for health care in the United States. The second most expensive country, by the way, is Switzerland. They spend $6,000 per year. We spend more on health care, and then we have to talk about Massachusetts versus Mississippi. And I can give you the same example, and we can use colon cancer instead of breast cancer. By the way, it's frequently the same states that haven't had the 35 to 40% decrease in mortality.
Dr. Lowy, this past Friday, you and your colleague, Dr. John Schiller, received the prestigious Lasker Award for your contribution to the development of the HPV vaccine, which protects against 4 major types of human papillomavirus, the most common sexually transmitted virus in the United States. I wanted to ask about vaccination rates of the HPV virus, which have been slower than hoped for in some states. Why is that, and how does that relate to other sorts of treatments for cancer that have not had the kind of uptake you and your colleagues would hope for?
Well, Fran, the first thing that I would say is that HPV vaccination is an area of prevention. Most of the attention for cancer research really is focused on cancer treatment because people are sick, it's really important to get them better, et cetera. But cancer prevention actually has the long-term potential of protecting against many more cases than treatment. And so it was really extraordinary for me to receive the award, not just for the award, but because of calling attention to the potential importance of prevention of disease. The uptake of the HPV vaccine has been lower than one might have anticipated, but this is true of many areas of prevention. Dr. Brawley and I were talking earlier, for example, about tobacco consumption. And we've known for more than 50 years that tobacco causes cancer of the lung, many other types of cancer, and cardiovascular, pulmonary disease, and yet many people still smoke. In terms of HPV vaccination, my expectation is that the new regulations, which go from 3 doses to 2 doses, will actually lead to a substantial increase in uptake, so that 5 years from now, we will actually have a fairly substantially high uptake. But the problem for HPV disease is primarily in the developing world, where 90% of the cervical cancer deaths occur, and there only 3% of people in the developing world are actually getting vaccinated. So our colleagues are starting a clinical trial to see if 1 dose of the HPV vaccine might be sufficient, because this could be a real game changer in the developing world because of logistics and cost.
Thank you. I wanted to ask a question that would relate to all the work that all of you are doing. Dr. Lowy, you first, and that is, each of you represents different disciplines: machine learning, genetic testing, cancer detection and treatment. How does the NCI tie that all together, and how do you all communicate with each other so that as each of you makes progress in your own particular field, it can all be brought together, and so a patient can benefit, patients across the country can benefit from those disciplines joining together?
We always have room for improvement. We inadvertently have ended up being siloed because people are focused on their particular areas of research. And going forward, team science becomes very important. Interdisciplinary studies become progressively more important. And we were talking earlier, for example, that using machine learning and deep computer algorithms can be enormously helpful, not just for patients making decisions, but also in terms of increasing our understanding and predictability of who is going to respond to what kind of treatment, et cetera. Because the amount of data that are accumulating now really is far beyond the capacity of any one person to be able to analyze.
Dr. Hickenberg, how are you connecting with your colleagues in your field, bringing together research disciplines that come back to you?
Yeah, in the area of inherited disease testing, there are several ongoing efforts, but there's some that I'm going to call out by name, NIH-funded projects that were developed specifically because of this very problem. We've gotten new technology that's really matured over the last 5, 6, 7 years. It's called next generation sequencing, and it's made the cost of sequencing your DNA just absolutely plummet. So where it used to be that we would look at your DNA, judiciously and infrequently, and usually only when you were very sick, now it's within rounding error, almost free to look at your DNA. The thing is that when it gets free, then we start looking at not just 1 gene or 2 genes or 10 genes or 20 genes. We start looking at 20,000 genes plus all of the other rest of the DNA. And so there's just a lot of learning that's going on very quickly. And as a community, we recognize that we were drinking from the fire hose. When we were looking at genes just once in a while and just little spots, we could handle it just fine. But this new technology really kind of forced us to get organized. And there's it's something called ClinGen and ClinVar, which, like I said, they're NIH funded. It's really all of the entire community of people who, genetic counselors, molecular pathologists, molecular geneticists, clinical geneticists, and we all kind of go and share our information at this site. So it used to be when I would, be interpreting a genome and I would see a novel variant, one that hadn't been reported before, or one that maybe it had been reported before, but I thought that the data was kind of janky. I would call up, my colleague, in Boston or wherever, and I'd be like, hey, so-and-so, I know that you're an expert in cardiomyopathy. Have you ever seen this variant before? And what is your evidence for how you classify it? And she, that's how we would work through cases, but that's just not scalable in the age of genomics. So now we actually have kind of crowdsourced that onto ClinGen and ClinVar. And that's where we collect the evidence for the disease gene association and for the variant disease association. And we've kind of all agreed upon ways that, systematic ways that you can score both of those relationships. So, kudos to the medical genomics community for pulling that together. It's still in its first few years of existence, but shows great promise.
Dr. Bartlett, I'm going to ask you first before I ask Dr. Brawley, because I'll ask a more specific question. Are you concerned about having sufficient funding for the work that you're doing?
Absolutely. I think that for all people who are sitting here, if you're thinking where machine learning impacted your life, when you go to Amazon and it recommends you a product, this is machine learning which makes recommendation. If you do your history, like your credit history check, again, it's machine learning. The only area where there is no machine learning is when you go to your doctor. All these amazing advances in machine learning that happen, they really don't impact our care, and in particular, our cancer care today. And today, we can say that from NIH funding, only 3% goes to engineering school, and even a much smaller portion of it goes to computer science and machine learning. And I think we've heard not only from me, who is a big advocate of the field, but from many people even before this panel who were saying how important it is to create personalization. And this is exactly what machine learning can help you to select the best option to cut the cost of care. We know that we severely overtreat because we don't know who is going to have really bad complications, who is not. Machine learning can predict it. In fact, in the case of breast cancer, we just currently finished a paper where we demonstrate for a case of high-risk lesions in breast, where in many hospitals like MGH, everybody get a surgery. Only 13% of women actually had cancer. So machine learning can help you eliminate all those unnecessary surgeries that are currently used. And coming back to your point about huge discrepancy in treatment, and I saw this map, and it was painful to see what is the difference between states' incidence and mortality. This is really painful, and here machine learning can really help you if you add automatic reading of mammograms and other things which both decrease the cost of care and also make the quality more equal across places. There we really can see a change, and I hope there will be some change in terms of foundations and government funding, bringing mainstream computer scientists and machine learning people to change it the same way as people who changed, retails in 90s when there was a Netflix challenge and other things, and all of a sudden machine learning became the central tool. So I wish to see the same thing happening in cancer care, and we are very, very far from this state now.
Dr. Burley, one of the most challenging jobs in cancer must be allocation. There's so many different studies, there's so many different directions. How do you, at the American Cancer Society, and you've had so much experience in government as well, how are those allocation decisions made? And at the very top level, how do you segment them so that you have enough representation of all the different detection, treatment, prevention to be able to fund all those streams?
Well, detection, treatment, prevention, and application of some of the things that we've already learned. One of my big messages is we are not applying a lot of the things that we already know. And some of those things, by the way, can be incredibly cheap and incredibly give us huge gain. We, in our basic science area, fund the lowest hanging fruit. And that is the questions that are most easy to ask, and we try to get people to address those questions and keep a very open mind. I don't like to get into disease Olympics, like more money for breast cancer, more money for prostate cancer. We have a wonderful drug now in lung cancer that came to us because of lymphoma research in the 1990s that found the ALK gene. The ALK gene is a kinase, it's a lymphoma kinase. Then thyroid cancer researchers found a drug that blocked the product of the ALK gene. And then finally some lung cancer docs married the two together, and we got crizotinib, which the FDA approved about 5 or 6 years ago. Unfortunately, it's only good for about 2% of people with non-small cell lung cancer, but it's a really important drug for that 2%. And here we have thyroid cancer and lymphoma benefiting lung cancer. I can show you examples where breast cancer has benefited prostate cancer. Fund the questions that are easiest to ask and keep a broad mind about how we can apply them to other things.
Dr. Lowy, that really gives us a great opportunity to talk about the Cancer Moonshot. New initiatives in the field of preventing, detecting, and treating cancer was passed by Congress in December 2016, which authorized $1.8 billion in funding. An initial $300 million has been appropriated in fiscal year 2017. What examples do you have? And actually, let me start with how does that allocation happen? You have this huge pot of money, and as Dr. Rob was talking about Cancer Olympics, I'm sure that every disease organization could say, with that amount of money, we would go very far. How do you sort through? How does the NCI sort through and figure out what are the best allocations?
Well, great question. We were extremely fortunate that there was the allocation from Congress. It's $300 million a year, actually, over a 7-year period, with the last few years being a little bit less. But as a result, we have been able to put out this year about $140 million worth of research that we otherwise would not have been able to do. Most of our research needs to be funded over a 5-year period, so you can't spend all of the $300 million in this particular year in terms of new efforts. But we had a group called our Blue Ribbon Panel, which we organized about 1.5 years ago. And actually, Tyler Jacks from your institution, from MIT, was one of the co-chairs because he was the head at that time of the National Cancer Advisory Board. They made a series of 10 recommendations, and these recommendations run the gamut from prevention all the way to survivorship, prevention, screening, treatment. I should point out that about 7 of those 10 recommendations we've started to implement them. But the reason that we had those recommendations is because of long-term, strong support that is bipartisan from both the Republicans and Democrats for biomedical research, which got to the point where more investment would lead to more advances. I would point out that our regular appropriation, that is for the NIH in general and the NCI specifically, really is far greater than that of the moonshot itself. Most of the clinical trials are done with regular appropriation. All of our basic research, we've ramped up the basic research in the last couple of years for NCI, but it still is at abysmally low levels, even though we have been fortunate enough to get increases in the regular appropriation. We fell so far behind because after the doubling in 2003, for many years, our budgets were flat while the investment, our purchasing power went down because of inflation.
Thank you. Dr. Higginboard, let's go from the very macro of funding allocation to the very individual of each patient. The tests that your company produces, they have to be ordered by a physician. Why is that so important?
Oh, good question. So my company is located in Silicon Valley, and it's kind of the heart of this kind of health tech movement where, you know, if you want to take machine learning and apply it to difficult health problems, that's what's going on in the Valley right now. And Color is one of those companies. And we've had the opportunity to kind of watch and learn from other companies around us and kind of look at the successes and failures and struggles. And one thing that we feel like was really important in making a successful health tech product was not to get the consumer outside the healthcare system, but to integrate the consumer better with the existing healthcare system. And so when we, in our typical Silicon Valley, you know, consumer-centric design theory, right, where you take a problem like buying a pair of shoes or hailing a taxi or getting a hotel, and you break it down and you say, what would be most delightful for the consumer's experience here? Clearly, our healthcare system was not built on this type of consumer-centric design theory. But if you were to do that to the genetic testing process, what Color has done is looked at what those users are that we want to delight, and it is both the physician, the healthcare provider, and the healthcare consumer. Because if you don't close that loop and you just go and you're trying to make a useful, satisfying, responsible, you know, health experience for the consumer, but when they take it back to their healthcare provider, the healthcare provider either doesn't know what to do with it or doesn't understand it or doesn't feel like they've been connected in the process, it's going to create an unsatisfying experience at the end to that healthcare consumer. So Color, in every step of their way, has always wanted to reduce the barriers to access to preventative genetic testing, you know, especially now that the price has gotten so low to provide this kind of service. So we want to break down the barriers to access, but are kind of very keenly aware that we've got to keep those touch points with the healthcare providers all along the way.
Thank you. Dr. Barzilai, one of the frustrations I know for cancer researchers is that clinical trial participation tends to be very low. What I wondered is whether in your fields of machine learning and AI, how will that augment the information that we're able to get on prevention and on treatment?
Well, this is an excellent question. Thank you. So first of all, let me start by saying that it is true that there are traditional machine learning methods do live on huge amounts of data, which for some cases may not be available. But let me just tell you a very short story that I just experienced it. Unfortunately, one of my students got diagnosed with ovarian cancer a few months ago. She's 24, and it was a very rare strain of ovarian cancer. She got 2 totally contrasting recommendations from doctors in 2 leading hospitals in Boston, which was very disconcerting for her. And then when I asked the doctor, why is it so? He told me, this cancer, only 10,000 women in the US get every year. We couldn't even enroll enough people for clinical trial. And my answer was, if you take 10,000 women for 10 years, you have more than enough patients for any complex deep learning methods to learn from it. Unfortunately, now this data is totally not used, so we don't know. So my first answer is we need to bring machine learning to utilize the data which is already there, which is just a dead weight in our healthcare system, which we don't use. Again, travesty. The second question in terms of clinical trial, that's exactly why NIH and other organizations need to bring main machine learning researchers into the field, because we do quite a bit of research how to deal with scarce resources, how to utilize data from multiple sources to help you when you don't have enough data. And that's why it's not enough just to recycle algorithm developed for lipstick recommendation into cancer care, which we currently do, but really bring mainstream researchers and change what is done to develop techniques which work for what exactly is needed to first understand better cancer biology and to develop more effective techniques for prevention and care.
Thank you. Dr. Burley, let's turn to population health for a moment. And one of your previous NCI hats was as director of the Office of Special Populations Research. Kaiser Permanente has published studies in the last few years showing that when you send patients who might not have been able to take the time off to do a colonoscopy, who might not have had the money for a copay, who might not have had easy access to a doctor, they began sending a stool test which can detect colon cancer in certain circumstances to their homes, and found that the uptake was fairly high, and that detection went up, and that at some point some rates of the cancer began to go down as well. How can we connect people who may not have the resources to travel, to have time, sure, who may not know about information? How can we have examples like this, ease of use, and be able to connect the best of what's in cancer detection and get it to more people?
By the way, that's a grand example of a very inexpensive test, stool testing, which, by the way, the science to support stool testing in screening for colon cancer is actually a little bit stronger than the science to support $2,000 colonoscopy. Not to say colonoscopy is bad. But that's a way of getting things to the people very cheaply in a large way and helping a large number of people. You know, the one thing I would do to help folks and to try to equalize these problems and to get this research to people is if I could get every person to have a good, honest relationship with a healthcare provider. It can be a general internist, a pediatrician, a family practice doc, a nurse practitioner, or a physician's assistant supervised by a physician. But if people could have a good relationship with someone where they could easily feel free and comfortable to talk about their health problems, those docs, by the way, would need to use computers in order to help them make some decisions. That would go a long way in getting people into the healthcare system, getting them evidence-based medicine instead of some of the practice that goes on now. I frequently get into trouble for saying this, but we sometimes practice faith-based medicine instead of evidence-based medicine. Faith-based medicine is the doctor does it because they're sure it works. They don't know anything about the science behind it, but it must work. We've done it. We've done it for the last 20 years. Evidence-based medicine is we've done the science and actually figured it out. If we started doing those sorts of things, we'd be also better. Our system would be cheaper, and we'd have better outcomes, the way the Europeans have better outcomes in a healthcare system that's cheaper than ours.
Thank you. To wrap up this really excellent conversation, and thank you each, I wondered if we could do a lightning round, and each of you would tell me, when you come here next year, when we come together again, a year from now, what would be something that you'd be able to share with the audience that was new in your field, something that is just beginning now, and that might be just the glimmerings, either the glimmerings or advanced results in whatever discipline, whether it's more communication, whether it's groundbreaking research, whether it's a hope for some things that are starting to percolate. Each of you would talk about the work that you're doing that is exciting. Dr. Lowy?
Well, I would pick cancer screening. I think we are going to end up in an era where the precision of cancer screening will go up, the range of cancers for which we will have cost-effective testing will also go up. It won't be for everything, but we will see incrementally improvements in this area, and some of them may be dramatic.
So as luck would have it today, Color launched a $149 BRCA1, BRCA2 test. And a few years ago, that same test would have cost almost $4,000. And we're actually running a promotion for Breast Cancer Awareness Month to do it for $99 with $50 testing of at-risk family members. And this is it's a physician-ordered test. It's a clinical grade test. You get access to board-certified genetic counselors every step of the way to help you understand the results and help guide you to your next steps and to work with your physician to make a preventative plan if you get a positive. And so what I would like to see is, and this is a quote actually from Dr. Mary Claire King, who recently wrote an opinion piece where every woman over the age of 30 should be getting BRCA1, 2 testing, that in 2017, and definitely in 2018, there's no reason that any woman with a BRCA mutation should be dying of breast and ovarian cancer.
Dr. Burrow.
I would, to take off on Dr. Lowy, I think we're going to have more screening tests. We're going to have a blood test looking for circulating DNA fragments that might indicate a person has an early cancer. I just hope that we actually validate these tests to actually show that they save lives before we start implementing them in the population the way we have with screening tests in the past. And then 20 years later realize that screening test actually doesn't save lives.
So what we are currently doing, we're already demonstrating that using deep learning and the raw data that we're collecting, like mammograms or pathology slides, can already make some really important predictions. What I would like to see in a year, and I believe we can do it in a year, is to provide full probabilistic progression of the disease so that we can reliably say, for women who is going to get cancer need to be screened differently, who doesn't need to be screened because their likelihood is so low, there is no point for them to come every year. And for people who unfortunately got cancer, to provide, again, likelihood of recurrences and the sensitivity to treatment.
Unfortunately, that's all the time we have for today. I'd like to thank our panelists, Dr. Barzilai, Brawley, Hagencourt, and Lowy, for participating in this really wonderful discussion, and to everyone in the room and those watching online. To find clips from today and more upcoming programs, please visit www.washingtonpostlive.com. Thank you all. Thank you.
Thank you.
Thank you.